So if your computer starts like glitching out, throwing error codes all over the place, um, you wouldn't try to fix that software bug by buying a brand new monitor.
Right. No, that makes no sense.
Yeah, I mean, you could swap the screen out, plug the new one in, admire how shiny it looks. But the second you boot it up, that glitch is still going to be sitting right there on the display.
Hmm.
Treating the hardware doesn't do a thing if the problem is, baked into the code.
That is honestly a phenomenal way to frame what we're seeing across modern healthcare right now, because when we look at the stack of clinical guidelines, psychiatric manuals, and surgical protocols we gathered for you today, a really clear, almost alarming pattern emerges.
Yeah, and it's something we don't really talk about.
Exactly. We are constantly treating the human body's hardware when the software is actually what's glitching.
And that is kind of the central mission for our deep dive today. We're exploring a question that seems completely counterintuitive in our culture of like really quick medical fixes.
Hmm.
When should counseling be considered absolutely mandatory before any physical treatment or surgery?
Because when you flip through these sources, you realize that taking a psychological pause isn't just some nice holistic bonus.
Right.
In a lot of fields, skipping that conversation and going straight for the scalpel or the prescription pad is, well, it's a recipe for active, measurable harm.
Oh, totally. And we see this realization sweeping across entirely different medical disciplines, right?
Mhm.
Like dermatology, gynecology, sexual medicine, even routine primary care.
Yeah, the medical community is really confronting the fact that human beings are not just, machines with replaceable parts. Our physical symptoms are incredibly tangled up in our perceptions, our anxieties, and our environments.
So let's start with what might be the most extreme, undeniable example of that hardware-software mismatch. We're talking about cosmetic surgery and specifically body dysmorphic disorder, or BDD. The numbers in these clinical documents are wild.
They really paint an intense picture. So in the general community, BDD affects around 1.9% of adults.
Okay, so relatively low.
Right, but then it jumps to 5.6% when you look at young women aged 17 to 19. And then when you look at the waiting rooms of cosmetic surgery clinics, the prevalence just skyrockets. In general cosmetic settings, 13.2% of patients actually meet the criteria for BDD.
And for rhinoplasty, like nose jobs, it hits 20.1%. I mean, 1 in 5 people walking in for a nose job has a diagnosable psychiatric condition centered on their appearance.
Yes, exactly.
But let me play devil's advocate for a second here, because the instinct feels so straightforward, right? If someone is intensely, overwhelmingly distressed by, say, a bump on their nose and a skilled surgeon goes and smooths out that bump, shouldn't that just solve the problem? Why do the guidelines explicitly warn that operating on these patients makes the disorder worse?
That's a great question. To understand the danger, we really have to look at the underlying mechanism of the disorder. BDD is not a physical deformity. It is entirely a disorder of perception.
Right.
The sources detail how individuals with BDD have this cognitive distortion where they selectively attend to tiny, sometimes microscopic aspects of their appearance, completely losing sight of the big picture. And the crucial piece is how they amplify the meaning of that perceived flaw.
So it's not just a passing thought of like, oh, I wish my nose was straighter. It becomes a proxy for their entire self-worth.
Exactly. The nose becomes the scapegoat for feeling fundamentally unlovable. The clinical term for that in therapy is often uncovered using the downward arrow technique.
Oh, how does that work?
Well, a therapist will ask, if your nose is crooked, what does that mean? The patient says, people will notice. The therapist asks, and if they notice, the patient replies, they'll think I'm ugly. And you just keep following that arrow down until you hit the core belief, which is usually, I am inherently disgusting, or I will be rejected and die alone.
Wow. Which means altering the cartilage in the nose does absolutely nothing to alter that core belief. I mean, you can change the shape of the nose, but the brain's internal panic button is still jammed down.
The software bug is still running. Surgery might provide a temporary neutralization of their anxiety, like a brief honeymoon phase. But that actually reinforces the maladaptive belief in the long run.
So they just find something else to fix.
Yeah, the brain simply shifts its agonizing focus to a new body part, or the patient decides the surgeon didn't do a good enough job and seeks revision after revision. It's this highly dangerous, endless cycle.
That puts surgeons in an incredibly tough spot, though. How do they stop the cycle when the patient is sitting there with a credit card begging for the procedure?
So the UK's National Institute for Health and Care Excellence, the NICE guidelines, have actually established a hard stop. Medical professionals are required to screen for BDD using 5 specific questions.
Okay.
One of the most telling is, on a typical day, how many hours is your appearance on your mind? Anything over an hour of obsessive rumination is a massive red flag.
Let me guess, if they hit that red flag, the scalpel's off the table.
Completely off the table. The mandated first line of treatment is psychological assessment. The evidence-based approach here is cognitive behavioral therapy, specifically utilizing exposure and ritual prevention, or ERP, and that's often paired with an SSRI.
Let's break that down for the listener, just because those terms get thrown around a lot. An SSRI is a standard antidepressant.
Yes, a selective serotonin reuptake inhibitor.
Right. So it basically turns down the baseline volume of anxiety in the brain so the patient can actually tolerate the therapy.
Yeah.
But what does exposure and ritual prevention look like for someone obsessed with their appearance?
Well, imagine someone whose ritual is spending, like, 3 hours a day applying heavy concealer to hide a perceived skin flaw, or constantly checking their profile in every mirror they pass.
Okay.
ERP involves deliberately facing the trigger without performing that safety behavior. A therapist might have the patient sit in front of a mirror without any makeup on and just sit with that immense anxiety.
Wow. So they aren't allowed to look away. They aren't allowed to cover up at all.
Exactly. They have to ride the wave of panic until the brain naturally realizes that the perceived catastrophe, like being fundamentally unlovable, isn't actually happening. You are rewiring the perceptual alarm system. You have to treat the software before anyone is allowed to alter the hardware.
That makes so much sense. But, that intense scrutiny of the physical body doesn't just stop at the face. This desire to surgically fix perceived flaws has moved into highly intimate areas, too. Which brings us to a massive boom in female genital cosmetic surgery, or FGCS, specifically labiaplasties.
Right, and the statistics in the clinical data show a 5-fold increase in labiaplasties in the UK over a single 9-year period. It is a staggering spike for a procedure that, historically, was quite rare.
The sources point to a sort of perfect storm of cultural shifts driving this, right?
Yeah.
You have widespread misinformation, the rise of pubic hair removal, which suddenly exposes and emphasizes natural anatomical differences, and then just the inescapable pressure of social media and pornography.
Oh, absolutely.
There is this intense manufactured demand for a very specific, neat, almost prepubescent look. It's like people are comparing their real, natural, asymmetrical bodies to these heavily filtered, airbrushed ideals.
Yeah, expecting your physical body to match a digital avatar.
Right? And then literally bringing that digital expectation into a doctor's office and asking a surgeon to make it happen.
And that creates a really profound ethical dilemma for healthcare systems.
Yeah.
The Royal College of Obstetricians and Gynecologists, the RCOG, issued an ethical opinion paper addressing this exact phenomenon.
And what do they find?
They emphasize that the desire for labial reduction in the absence of, severe physical trauma is very frequently a displacement for other forms of anxiety.
Displacement. So the anxiety a person feels about their life, their relationships, or just their general sense of self-worth gets funneled down into this one highly specific, hidden physical focus.
Yes, exactly.
It's easier to say my body's wrong
Right.
than to say my life feels out of control.
Right. So if you know the request is driven by cultural anxiety and media distortion, do you operate? Systems like the Greater Glasgow and Clyde Health Board have drawn a very hard line here. They do not offer this surgery for purely cosmetic reasons. It is restricted strictly to medical necessities like repairing significant trauma.
But if a patient goes to their GP, fully convinced they need this cosmetic surgery because they feel abnormal, how does the doctor handle that? They can't just say, no, you're fine, and send them home to suffer with that anxiety, right?
No, of course not. The professional guidelines dictate a mandatory psychological pause. A psychology referral must be considered in primary care long before a gynecological surgeon is ever involved.
I am fascinated by what that counseling session actually looks like. I mean, how does a psychologist talk someone out of a surgery they deeply want?
Well, they don't really approach it as talking them out of it. They approach it as unpacking the request. The psychologist explores the timeline, when did this distress start? Was it after a comment from a partner? Was it after consuming certain media?
Oh, so looking for the root cause.
Right. And a huge part of this intervention is simply education. The therapist will use medical diagrams and photography to show the patient the vast, massive range of normal human anatomy.
Because society has completely skewed their baseline of what normal even looks like.
Exactly. By addressing the underlying anxiety and correcting the misinformation, the distress often dissipates entirely. The goal is to align the patient's perception with reality rather than surgically amputating perfectly healthy tissue to meet some fleeting media-driven trend.
It's really powerful to realize that sometimes the most ethical medical intervention is refusing to do a medical procedure.
It really is.
Now, let's shift our focus from the physical appearance of intimate areas to the actual function of them. We're talking about sexual dysfunction. And this is where the connection between the mind and the body gets incredibly tangible.
Yeah, patients almost universally assume sexual dysfunction is a mechanical failure. The sources cover a range of conditions like erectile dysfunction, loss of libido, dyspareunia, which is painful intercourse, and vaginismus, which involves involuntary muscle spasms that make penetration incredibly painful or physically impossible.
Right, so if a patient can't get an erection, or if sex feels like hitting a literal physical wall, the immediate thought is, my plumbing is broken, like I need a pill to force the blood flow, or I need a physical exam.
Yes, exactly.
But if the physical mechanisms are technically intact, and it's the mind shutting the valve, how does sitting in a chair, fully clothed, talking to a sex therapist, fix a highly physical reaction like pain or erectile dysfunction?
It comes down to understanding the biopsychosocial model of human arousal. The human brain is a master protector. Its primary job is to stop our physical selves from doing things it believes will cause us damage, whether that damage is physical or emotional.
Okay, that makes sense.
So if a person is dealing with severe stress, performance anxiety, relationship distress, or past trauma, the brain views the vulnerable act of sex as a threat.
The brain basically slams on the emergency brake. It floods the body with stress hormones, the sympathetic nervous system kicks into fight or flight mode, and the pelvic floor muscles literally brace for impact.
And when your nervous system is in fight or flight, biological arousal is impossible. Blood flow is diverted away from the genitals to the major muscle groups. You can, run away from the perceived threat.
Right. Yeah.
So if a doctor just hands a patient a pill for erectile dysfunction, that medication might mechanically force blood flow, but it does absolutely nothing to stop the brain from panicking.
The software is still screaming, danger, even if you have manipulated the hardware.
This is exactly why psychosexual therapy, or PST, is highlighted in the guidelines as a crucial prerequisite or alternative to medical treatment. And to clarify a common misconception, the sources emphasize that professional sex therapy never involves physical contact or examinations in the therapy room.
Okay, so if there is no physical examination, how are they treating a physical dysfunction?
They utilize cognitive behavioral therapy to address the mental blocks, but the cornerstone of the treatment is actually behavioral homework, most notably a technique called sensate focus.
Oh, I saw this in the notes. Sensate focus is like a structured touching exercise for couples to do in the privacy of their own home, right? But the most interesting part is the golden rule, which is that penetrative sex is strictly banned.
Yes. By banning the ultimate goal of intercourse, you immediately remove all of the performance pressure. The couple is instructed to spend time together focusing entirely on non-genital sensual touch, back rubs, holding hands, exploring the sensation of touch without any expectation of what comes next.
It acts like a pressure release valve. If the anxiety stems from the fear of losing an erection or the fear of pain during penetration, taking penetration off the menu means there's nothing to fail at and nothing to fear.
And over weeks, as the exercises progress, they are slowly rewiring the brain's association with physical touch. They're moving the nervous system's response from anxiety and pain back to safety and pleasure.
It just completely short-circuits that anxiety loop.
The clinical texts point out a really poignant reality here. For many patients, sitting in a sex therapist's office is the very first time they have ever been in a safe space to honestly explore their beliefs about sexuality.
Wow, yeah.
They unpack the cultural messaging they absorbed, the shame they carry, the unresolved resentments in their relationship. By treating those psychological blocks, the body's functional blocks simply melt away on their own.
It's a brilliant reminder of how much control our nervous system has over things we think are purely mechanical. Now, you might be listening to this and thinking, okay, cosmetic surgery, intensive sex therapy, these are highly specialized fields. This doesn't really apply to my standard everyday trip to the doctor.
Right, but it absolutely does.
Yeah, the sources reveal that the necessity for psychological assessment extends all the way down to the most routine reproductive health care.
This brings us to a really fascinating look at how we view the standard medical transaction. We tend to think of primary care as drive-through. You go in, you ask for a specific service, the doctor provides it, and you leave.
pretty much.
But when you look at the clinical guidelines from the British Association for Sexual Health and HIV, or BSHH, specifically regarding prescribing contraception, the hidden complexities are immense.
Yeah, on the surface, it seems like the simplest interaction in medicine. A patient walks in, says, "I'd like to go on the birth control pill," and the doctor writes the script. But the guidelines emphasize the absolute non-negotiable necessity of trauma inquiry and screening for intimate partner violence before any medical decisions are finalized.
The clinical mandate is that doctors must act with deep situational awareness. They are not just evaluating the patient's physical ability to tolerate a hormone, they are evaluating the safety of the patient's environment.
The tension here is incredible. How does a doctor navigate that in a standard, like 15-minute appointment? If a patient comes in asking for the pill, the doctor has to figure out if handing over that prescription might inadvertently hand a weapon to an abusive partner.
It requires an incredibly delicate strategic approach. The guidelines stress that clinicians must inquire about trauma and domestic abuse privately. It must be a one-on-one conversation.
Which is complicated if a patient brings a partner or a family member to the appointment.
Very complicated, especially if there is a language barrier and the family member is acting as the interpreter.
Because the person translating the doctor's words might be the very person inflicting the abuse.
Exactly. The clinician has to find a creative, non-threatening way to separate the patient from the partner. They might ask the partner to step out to fill out some administrative paperwork at the front desk, or they might take the patient into a separate room under the guise of needing a routine urine sample or a blood pressure check.
Oh, that's smart.
They buy themselves a 60-second window of absolute privacy to use a professional, independent medical interpreter and ask, "Are you safe at home? Are you being forced to be here?"
Because the core issue that texts focus on here is reproductive coercion.
Right.
You might have an abusive partner who is highly controlling about the patient's body, or who is actively trying to force a pregnancy to trap the patient in the relationship.
Right. So if a doctor skips that counseling pause, if they just rush through the 15-minute slot and hand over a prescription for daily birth control pills, they are giving the patient a highly visible method of contraception.
Oh, yeah. A blister pack of pills is easily found in a purse or a bathroom cabinet.
Discovering those pills could trigger a severe, potentially fatal episode of physical violence at home.
Wow. The medical fix, the simple prescription, literally becomes the catalyst for violence.
But if the clinician takes that pause and creates a safe space for the patient to disclose their reality, the entire medical trajectory changes. The doctor discovers that the patient actually needs a hidden method of contraception.
Like what?
They might opt for a contraceptive injection or an IUD where the doctor intentionally cuts the strings very short so the partner cannot feel them.
So the doctor isn't just managing reproductive health at that point. By stopping to talk, they are literally engineering a physical safety net for the patient's life.
This is the very foundation of trauma-informed care. The clinical texts outline the core principles, which are safety, trust, empowerment, collaboration, and choice. By embedding those psychological principles into a routine visit, the doctor ensures that the medical treatment they provide is actually safe for the patient's holistic reality once they walk out of the clinic doors.
Let's pull all these threads together because the through line across all these sources is pretty unmistakable. Whether we're looking at a cosmetic surgeon using a 5-question psychological screen before altering a nose, a gynecologist requiring a therapy referral before agreeing to a labiaplasty, a sex therapist treating physical dysfunction with communication exercises instead of prescriptions, or a primary care doctor separating a couple to screen for coercion before prescribing the pill.
The consensus is universal. You have to evaluate the mind before you alter the body.
Right. The biopsychosocial model is the unavoidable reality of human health. We are deeply complex, interconnected systems. Your beliefs, your cultural conditioning, your traumas, your anxieties, they don't just live in the abstract space of the mind.
No, they manifest physically. They alter your nervous system. They change your muscle tension. They dictate your physical safety. Treating the physical manifestation while ignoring the psychological root is like putting a Band-Aid on a check engine light. It is at best ineffective, and at worst, it causes catastrophic harm.
It totally transforms how you think about your next doctor's appointment. For you listening, the next time you find yourself seeking out a physical fix for a discomfort, it's worth taking that pause yourself. Are you treating the root of the issue, or are you just trying to silence a symptom?
And as we look at the trajectory of modern medicine, I want to leave you with a thought regarding where this is all heading. We are rapidly moving toward a highly commercialized, on-demand model of healthcare. You can hop online, fill out a quick multiple-choice questionnaire, and have erectile dysfunction pills mailed to your door. You can scroll through Instagram and book cosmetic surgery consultations through an app.
We're basically prioritizing hyperconvenience and consumerism over holistic care.
Exactly. The friction is being completely removed. You can basically click add to cart for medical procedures.
Which is terrifying when you think about everything we just discussed.
And the dangerous question is this. As we optimize for speed, are we engineering this vital counseling pause out of the medical system entirely? If we lose that psychological gatekeeper in the name of convenience, how much unnecessary physical harm, how many endless cycles of dissatisfaction will we inflict on ourselves in the relentless pursuit of a quick fix?
Wow.
It challenges all of us to radically slow down and perhaps ask why we want a treatment long before we figure out how to get it.
Because if we never stop to figure out the why, we're just going to keep buying new computer monitors, plugging them in, and wondering why the screen is still glitching.
A perfect place to leave it.
Thanks for diving deep with us today. Keep asking those questions, keep looking for the root of the glitch, and we will see you on the next one.